are Dr. Leslie Coulter and Dr. Christa Sinclair-Mills. And they're going to be talking about house calls, delivering exceptional care to homebound seniors during a pandemic. So Dr. Sinclair-Mills completed her medical degree at McMaster University and then her residency in family medicine at the University of Toronto. After graduating from residency, she joined the house calls team, operating out of Sprint Senior Care in Toronto, and as an associate physician. And she's now the medical services lead for the program. House Calls as a mobile interdisciplinary team serving frail seniors in the Toronto Central LHIN. And this work allows her to combine her passions for geriatric primary care and enhancing access to medical care for vulnerable populations. When she's not driving or cycling to a patient's residence, she can be found at home with her 2 boys and her dog and her husband, likely fixing someone a snack. And I upgraded Leslie to an honorary doctorate, but she should, because she's taught me an incredible amount as an incredible occupational therapist. Leslie is a community occupational therapist associated with VHA Rehab Solutions, and she's been working with them for 15 years. For the past 12 years, my goodness, Leslie has dedicated her career to providing clinical care, leadership, and program management to the House Calls program, as you've heard about. Leslie is also a proud mother of 2 daughters and a Labrador retriever as well. So over to you, and then we're going to do your Q&A session starting at 10:20. Take it away.
Great. Thank you very much, Samir. And ultimately, as you already mentioned, a lot of attention really hasn't been given to the community. So we really appreciate this platform. And I also appreciate that we got Javar as our character, because those of you that know Aladdin, he's very grumpy, and Samir does a lot of geriatric consults for us. So he knows we have some grumpy patients on our caseload, so it works very well. Now, Christa and I are going to be speaking today about our program, House Calls. It's a program that operates in Toronto, and we're going to just tell you a little bit today about how we've been managing over the last 3.5 months. And it's 2020, so technical difficulties are expected. Sorry, else I can't advance my slides. Oh, nope. Those aren't them. Okay, let's try again. Okay, great. Any questions that you might have about our program, they can be found on our website, seniorshousecalls.ca. And Christa and I also provide our email address at the end of the presentation. So by all means, if you'd like, you can reach out to us with any questions that we aren't able to answer today, or if you want to do any resource sharing, we're certainly open to that. So briefly as an agenda today, for the next 30 minutes, Christa and I are going to speak about house calls, how we've been managing to deliver safe and appropriate care during the pandemic, how we're trying to keep our team and our patients protected, both through PPE and virtual care. And then we are going to follow up with some of the barriers to care. And there have definitely been some bumps along the road, maybe attributed to the fact that not a lot of the guidelines that were coming out were designed for community. So we had to do a lot of research and adapting to work for our team. And then really our ongoing plan will discuss with you how we hope over the next 18 months to continue throughout and provide excellent care. So thanks to Dr. Novachinsky, our clinical director. Actually, in Samir's presentation, there was also one of his photographs. And it's a really great opportunity for you to see these photos to get a glimpse into the lives of our patients. So we've been around since 2007 and got some aging at home strategy funding in 2009 with an increased base funding in 2018. So over the last 13 years, our team has grown from a team of 4 people to a team of 17. But that's not to say that hasn't been a lot of fighting tooth and nail and a lot of advocacy. And thank you to Dr. Sinai, who's done a lot of that advocacy for us. And a lot of our program has been driven on donation dollars. And we at House, I didn't switch, yep. So at House Calls, we provide full-time, ongoing interdisciplinary care to homebound seniors, those whose needs would not, who are not able to access primary care. And we always use the tagline that we are the necessity and not necessarily the convenience. And as Samir mentioned, House Calls is a collaboration between VHA Home Health Care, VHA Rehab Solutions, and Sprint Senior Care. And I can tell you, being in a pandemic, it takes all hands on deck, and we've been using all the guidelines and information coming out of these agencies to really support us and drive our care. And with Sprint Senior Care, they have already Meals on Wheels and transportation to medical appointments and transportation in the community. And then they were such a wonderful agency. We were identifying that people were really having a hard time getting groceries. I mean, I don't know if you remember, but even those who used to order from Grocery Gateway, there was delays of 2 weeks. So Sprint really stepped up to the plate, and they ended up doing a voluntary grocery delivery program, which has been excellent. Sorry, next slide. Sorry guys, I don't have control. So I'm gonna just read recently in the Globe and Mail by Andre Picard. He wrote, "One of our priorities has to be allowance of people to age in place, to give them the choice of living at home and dying at home with proper supports." And if I can say one thing about House Calls, we provide this opportunity. Next slide. So as I mentioned, we do work in Toronto, and we cover almost 80% of Toronto Central. The reason, when you look at this diagram, whether you see a squirrel or if you might see a dog, depending on which end you're looking at, we do have some gaps, and that's because there are other teams that are operating and providing primary care at home. Baycrest is to the north, to the south is St. Joe's and Toronto Western, and to the east, Michael Garron. So, but between all of us as a collaborative, we're providing house calls and care to seniors in Toronto. And as I mentioned, we have 17 team members. We have 9 providing primary care. We have an excellent group of social workers, occupational therapists, physiotherapy, and 2, we couldn't live without team coordinators that sit in the office. The rest of our team is mobile. And we have some access to the Toronto Central LHIN. Their care coordinators will attend our weekly rounds. And we also have access to Dr. Samir Sinha, who does some geriatric consults, and also Dr. Carol Cohen out of Sunnybrook Hospital, who provides some geriatric psychiatry consults as well. And truly you can see by this Venn diagram that our patients are vulnerable. And boy, were we worried when this pandemic hit, because not only do they have many medical comorbidities, but they also likely have some cognitive impairment, and on top may lack some social supports. So in order to be eligible for our team, you need to qualify for at least 2 of the categories. So for instance, you may be bedbound because of a physical issue, and you may have no supports to get you to your family doctor. But being housebound doesn't necessarily mean that you're not mobile. We have some who are very active, however, have dementia and perhaps aren't remembering to make their way to the family doctor's office and don't have the supports to take them there, and that's how they come on our team. But truth is that majority of our patients do fall in all 3 categories. And we have a caseload of about 430 patients with an annualized caseload up to 800 per year. So you can tell that we do have quite a bit of attrition, whether it's because of a move to long-term care or because of a death. And our physicians do provide end-of-life care in the home, which is fantastic for our patients. And we also work with the Tammy Latner Center, and sometimes we'll do a shared care in order to allow our patients to die at home. And referrals come from all over the place. Sinai is certainly one of our big referral sources, as well as the LHIN. And then that 20% is from, can be self-referral, could be a neighbor, a concerned family member, even somebody delivering Meals on Wheels at Sprint will say, hey, I think you might benefit from the House Calls program. And you can see our patients are older, 88 being the average age. And we can make upwards as a team of 10,000 home visits per year. And we do a lot of teaching. So there I am with one of my students. So all of a sudden, it's March. And at the time, it was a bit what we thought maybe of a curse. One of our physicians was down in Boston at a conference, and there was an outbreak there. And luckily, our physician didn't get COVID, but it really kind of sparked a light underneath us to say, you know what, this is here, and let's get going. We got mask fit tests right away. We started looking at virtual platforms for our rounds. And probably the best thing that we did is that we developed early on a pandemic planning group, which is consisting of Christa and myself, Dr. Elizabeth Nidra, and NP Lindsay Jones. And between us, we were meeting regularly, a couple of times a week, and we were poring over information coming in from public health, the CDC. Samir had passed along a great resource, HCCI, the Home Centered Care Institute. And early on, we were able to learn what they were doing, like the Mount Sinai team down in New York, and how they were delivering house calls, and we could adapt some of the information that they were giving us to our practice. And one of the other key ingredients is that Christa and I, although we both sit on the executive committee for house calls, we're both clinical. So we realized early on that decisions that we were making for our team were also going to directly affect our safety, our patient's safety, our family's safety. So we were quick to react, and we developed some team guidelines. I'm just going to advance slide. Hopefully, there we go. And this is guidelines. You can see it's been updated. June 1st was the last revision, but we really wanted to provide our team with understanding of what PPE they should be wearing when they're out there, what should the visits look like, and a quick reference to go, because it's not like when you're in a hospital and then you have signs posted up everywhere like, oh, am I supposed to take my gloves off and then my mask, when you're out there in your back of your car and it's a heat wave. And so luckily we have those quick references to look at. Next slide. So another thing that I think we did really well is that we sat down right away and we we looked at our entire caseload, and we deemed those that were vulnerable, and I'll talk about that in a minute. But of our 430 patients, every single one of them, and this came out of the HCCI, to give them an outreach safety call to see, hey, do you have your medication? Do you have your supplies? Do you have access to groceries? And we kind of joke on our team, like, this is the Super Bowl for some of our patients. I mean, they have been training for a pandemic, staying indoors, isolation. And so some of the times when we were calling them, they were giving us advice on how to keep ourselves engaged and motivated. And we were also just able to say, hey, how are you doing? This is scary. I feel scared. How are you doing? What can we do to help you? And as I mentioned, we had the grocery delivery program, which could provide the essentials and the groceries within like 1 to 2 days of them ordering it. It's amazing. We also, from donations that the House Calls team, 100% of donations go towards we could buy essentials for some of our lower income patients. And we have an equipment donation cupboard. So if somebody was saying, I'm really having trouble with walking, we were able to supply them with some of our equipment. And then also what we did early on, right before pandemic hit, we were getting about 12 to 20 referrals per week, and we were accepting between 8 and 10 of those. And so we had to put a bit of a temporary hold. We never wanted to close, because we realized this is definitely not the time to be closing access to care. But to preserve the capacity of our own team for our current patients, we ended up saying that, we still continue to accept referrals if they are medically urgent or if they're quite vulnerable, such that we know our involvement will have a positive outcome for that individual and prevent a hospitalization. Next slide. And so, yeah, that was our objective. At first, it was, let's keep our people home. Let's keep them out of hospital. Let's maintain the system capacity and care for them in the place that they want to be. And we also, as I mentioned, with those outreach calls, wanted to provide that safety net, because for a lot of our folks, they maybe weren't getting those regular visits from family to care for them or deliver groceries or set up their medications, because the family didn't want to put them at risk of exposure to COVID. And then we also were finding that a lot of our patients were putting a hold on their PSW services because of fear of contracting it from their PSW. And so we wanted to make sure that they knew we were there and we were there for them if they needed us. And of course, another objective was to protect ourselves, protect our patients, whether through use of PPE or virtual care, and also to find PPE. And Christa's going to speak to that in a moment. And so some of the steps, I'm going to go through each one of these. Who's going to get the in-person and who's going to get the virtual visit? So we had to determine what was an essential reason to go out and see someone. And next slide. And this was the list of some of the reasons early on, and actually that we continue to use this list of why we'll go out and do an in-person visit. So whether they're having a functional decline or a decline in their medical condition, if they're one of our palliative or end-of-life care patients, if they're at risk for safety, whether because of needing a lift or transfers, mobility, having falls, home safety risk, and certainly some food insecurity, those would all be reasons why our team member would go out. And we had great direction again with this guideline. I know it's a little bit hard to see, but it helped us to sort of identify, okay, should they go in? If I'm going in, what do I need to wear? Okay, what can I leave for virtual, and what kind of platform can I use? So it was a really helpful guideline to have. And then we determined who, again, is most vulnerable. So right away, every single team member, we generated a list, spreadsheet on our EMR to just review, okay, who needs to be seen, whether it's because of medical reasons or because of social frailty. Who are those people that are not going to be calling us? So we need to stay on top of them. We need to figure out with our folks, develop these care plans to find out how frequent should we be visiting you? How would you like us to contact through you, through your daughter, your son? And what is the focus of our check-in going to be? And so Allied Health early on, because we had to limit the number of visits to just those essential reasons, this was a great task for our team to take on. And constantly throughout this whole time is going through and just constantly reevaluating our list. Do we need to add some folks? Can we take some off of that list? Next. And as I mentioned, some of the things that we did right, Christa, I left all the bad stuff we've done to Christa to talk about, is also came out of the HCCI, that already we recognize that when you work in the community, it can be quite isolating. It's not like you get to see your colleagues passing in the hallway. Unless you're doing a joint visit, you're out there, you're kind of a lone wolf. So we started with a Monday morning 9 to 9:30 huddle, where we really had no agenda other than just to chat, to check in with each other, to just say, hey, how are you doing? Hey, have you seen this meme? Like, what's going on in your life? And it was a really great way for us to stay connected. And then we also, it still makes me kind of sad. We see the picture, the image, that's how our rounds normally used to look. And we love that time and being together and being able to review all of our caseload. That's not a typical picture. I see one of Christa's baby's feet I'm holding actually, but we had to unfortunately move that. We couldn't obviously be in person to have our rounds. So we've now moved to virtual rounds using Microsoft Teams. Next slide. And I remember the first time I saw the 9-person collage of on a Teams meeting, and I was like, oh my gosh, this is like the Brady Bunch. Like, look at this, look at us. But then after, months of like, turn your microphone off, keep your phone away from the computer, we're getting too much feedback. I think like, this isn't Brady Bunch. Brady Bunch, they used to like smile at each other. This image I feel is more what our rounds now looks like. Next. Oh, can we just go back up? There we go. And I'm going to pass it over to Christa, who's going to tell you about our PPE and keeping us all protected.
Perfect, will do. And I think despite my best efforts, I don't have control of the slides either. So I'll let you guys know when I'm ready to go. So I think Leslie gave a great overview of how we figured out when we would need to go in and actually see a patient and determine what the best way is to conduct a visit. And so I'll get into a little bit about how we actually set ourselves up for success when we actually conducted some of these visits. How do we make sure that we're doing them safely, both for our own sake and for our patients? There was a lot of anxiety on the team initially, and still is, about making sure that we don't become vectors for COVID to our patients. They are very vulnerable and continue to be so. And so we had to figure out, so how do we do a house call now that it's here and we have to deal with it? And so I am kind of a sucker for internet pictures. So this guy popped up early on and I thought, yes, this is our guy. This raccoon has it all figured out. He's washing his hands all the time. He's always wearing a mask. So this is who we have become through COVID. Initially, you probably all will have had the experience that PPE supply was a huge concern early on. And so we wanted to ensure that we established a robust and fairly reliable supply chain for our PPE. One of the challenges we had is, since this was new to us, we didn't know what our burn rate would be. We knew how many in-person visits we made pre-pandemic, but then when we changed some of our visit protocols and moved a lot to virtual care platforms, we had to figure out how many in-person visits we were doing now, and by extension, how much PPE we would need to secure. So we set up a spreadsheet to track our telephone versus in-person visits, figure out what kind of PPE usage we were having over time. And again, as Leslie mentioned, we were very lucky to have a strongly established network of community partners who we could work with to secure PPE when we ran short in short term, and nasopharyngeal swabs when we at some point ran out. So we were very lucky in that way, but this was a big hump to get over initially. There was also if we can go back, the frequent reviewing and updating of PPE guidelines, which the pandemic planning team took on. This was sort of drinking from the fire hose of guidelines early on, and then continuing to update as we go along. And then using virtual care when appropriate as a means of preserving our PPE. So virtual care was sort of a novelty for us in the geriatric primary care home visiting world. This was not something we did an awful lot of. I certainly would have done occasional telephone check-ins, but this was not sort of part of our standard procedure for visits. What we have been finding as we're getting more comfortable with it is there's a good role for it in terms of particularly triaging urgent calls that come in, as well as engaging in routine follow-up visits with the appropriate patients. And I think this is where it's very important that you know your patients and you know their abilities quite well, so you can determine whether they can manage a telephone visit. We also use it to conduct joint visits. So as a way, again, of minimizing a patient's exposure to multiple team members or to multiple care providers. So if, for example, if I was going to do a visit that had to be in person, and one of my colleagues also needed to connect with them, I would facilitate a virtual visit, or I would facilitate with a specialist who perhaps needed to do a follow-up, cardiology, respirology, et cetera. And we use the telephone to help minimize the amount of time we actually spent in the home. So prior to actually entering the patient's home, I would sit in my car, I would call them or their care provider, their caregiver, and I would get a history, conduct much of my assessment over the telephone, and then I would do a very targeted and as brief as possible physical examination in the home. We found this was helpful just to ensure we weren't spending an hour in the home with them and exposing them to more risk that way. We know, as you guys have probably all gotten very tired of, there are many, many, many virtual platforms for care. Some nicer than others. What we have found is that telephone is probably the easiest medium for our patients simply because of their access to technology. We don't have a lot of patients who have internet access, computers, and who can use a new platform at the drop of a hat. And so unless they really had a family member or a caregiver who could facilitate a virtual visit, telephone was the name of the game. But there are other difficulties around sensory impairments, which I'll get into a little bit later as well. And if you go to my next slide, which is this was me much of the pandemic and still is. Can you hear me? I'm on the phone. Nobody can hear what I'm saying, but we're dealing with it, we're making it through. And I just want to highlight here under our visits, we were interested to know whether the number of contact points that we had with patients changed at all when we switched to a virtual care plan. And so we looked at our encounter numbers, and this would be either in person or telephone from March 17th to June 17th, 2019, and then the same period this year. And what we found reassuringly, actually, I think, is that we continue to have the same number of encounters with our patients approximately. Our caseload was perhaps a little bit higher this year than in the past year, but these are just our first numbers that we're taking a look at. And I think this is reassuring. What we want to do is, I think there's lots of room for some interesting research going forward in hospitalization rates of our patients, mortality rates, and sort of per capita encounters with patients. So we'll see where all of this lands in the next little bit as we catch our breath and can conduct some research. We in the community, and particularly in the home care world, we are very used to barriers to care. Certainly, COVID has introduced some brand new ones to us. The big challenge with PPE really is that there is not a guideline precedent for in-home pandemic personal protective equipment and infection control. It is a very different world than it is in the hospital. I don't believe that you can get true isolation and perfect PPE in the home environment. I don't have a negative pressure room to see a patient in. I don't have an ante room. I don't have a sink outside the room. But we do our best. And so we put together, by reading from some of the experiences from the Mount Sinai visiting doctors team in New York, as well as the McMaster Palliative Group here in Ontario, put out lots of great guidelines around how they were managing. And so we adopted some of that. And so you'll see this is our new PPE donning and doffing station. It's the trunks of our cars. So we are those sort of strange people in full PPE spraying bleach all over our equipment between visits. We adopted a clean bin, dirty bin system. We found this to be actually quite effective and helps keep things neat and tidy, and minimizes the chances of cross-contamination as much as possible. But certainly PPE donning and doffing is a challenge for us and continues to be. We also used to take our laptops in and chart as we went, and we would have great access to the patient's chart on our EMR. We no longer take our laptops into visits so that they don't become a fomite for infection. So that is a bit of a challenge, particularly if it's a patient that I'm not quite as familiar with. I'm having to go back and forth between speaking with them in person, going back to my car, checking my computer and so on, and making sure that I understand exactly what's going on. There are no public washrooms available. We rely quite heavily on popping into a restaurant or a coffee shop for using a washroom. Many of our team members drive in from out of town, Milton, Cambridge area. And so for them, this is a big barrier, not having access to a washroom. There's also no air conditioning, and if you haven't noticed, summer is finally here, and it is very hot when you're walking around in 30-degree weather with your mask and your face shield on. It's very uncomfortable. And I will say personally that because I'm trying to avoid donning and doffing my mask multiple times in the day, I'm perhaps not hydrating as much as I usually am. And so there's been a physical challenge to having the PPE on that I hadn't anticipated initially, but certainly is starting to rear its head now as we get into the warmer weather. Next slide. I also, one thing that sort of may not necessarily be a barrier to care, but it's something that I think has made some of our team members a little bit uncomfortable, is that historically we tend to fly a little bit under the radar when we do a patient visit. We're fairly unassuming. I wear fairly unremarkable clothes. I may have a backpack, but it's not easy to tell that I'm a healthcare provider, that I'm a physician going in to do a house call. Things are a little bit different. I'm now in my scrubs. I'm wearing my mask, my face shield, my scrub cap. I've got my gloves. I've got all of my equipment with me. And I think in a way it sort of reveals the patient when I walk up to their house or I'm in their apartment lobby. I look a little bit scary. I stick out a bit. And I'm uncomfortable with this, but I'm not sure that there's a way around it, unfortunately, but it's something that I'm mindful of for sure. There's also, I'm sure you've all, oh, we can go back. There are lots of challenges in working with individuals with cognitive or hearing impairments while I'm wearing PPE. So a mask does not allow our patients to do any lip reading, and many of them rely, at least to a certain extent, on lip reading to understand me. The mask also muffles the sound a little bit, as does the face shield, and I can't express my emotion as easily because they can't see my face. So that certainly makes it harder to communicate. And there are limitations to virtual care, which I think, particularly telephone care. I admit to being a virtual care skeptic, particularly when it comes to our patient population. I think there may be a small limited role for it, but a house call is a full sensory experience, and you learn an awful lot by walking into the patient's environment, observing it, observing the way they interact with their environment, whether it's checking blister packs or the lack of blister packs. And then, of course, there's the infamous fridge biopsy, which is very, very important. This was a picture of a refrigerator of a new referral. I think Leslie saw this patient. They were allegedly receiving Meals on Wheels, but were not eating them. So we wouldn't have known this if we had done a telephone visit on the patient. So we recognize that telephone care, while it's good and it has its role in the current context, may not always be the perfect platform for care.
Just 1 minute warning.
Thank you, Samir. I will speed up. So early in the pandemic, we had very recently seen all of our patients. And so we had a sense of how they were coping, what their functional status is. And it was easier to determine whether a particular patient would be able to manage with a telephone assessment or whether an in-person assessment was really required. Where we are now is we have a little bit less certainty around that. What's their level of function? Has it changed over the last few months? And perhaps they need a visit just so that we can get a sense of where their baseline is at the moment, so we can provide them with the best management plan in future. Next. And so at the moment, we continue to prioritize visits that reduce hospitalizations and complications. This has been the litmus test for us for whether a patient needs an in-person visit or not. We want to continue making sure that our patients know we're available when they need us, whether it's virtually or in person. We are out there doing visits. And we're working to develop strategies for the longer term care of our stable but medically complex patients. This is going to be our new normal, at least for another year to 18 months, 2 years, who knows. And we want to ensure that we are staying flexible and proactive and making sure that we are implementing the right strategies to keep our patients safe at home. And this is what we in the community are used to. And I think we do pretty well most of the time, although this has been a curveball of a few months for us. All right. Thank you.
Thank you.
Perfect. So Christa and Leslie, as usual, thank you for an incredible presentation. We have a tremendous number of questions, and I do hope that you will be able to participate in the chat room as well to answer some of the questions that have come in. But we have a few moments to, so I'm going to try and pick out a few of the amazing ones. One of the questions was, this is a vital service. Are there any projections as to whether this initiative might be expanded to the GTA and beyond? Is there a way we can better address the disparities in access to home health services in more remote geographic locations?
That is a great question. So I think there are two parts to this. So the one is, will this expand through the GTA? So I think our objective has always been that we would love to cover a larger part of the city. And whether that means having replicating different teams to go into different parts of the city, I'm not sure the answer, but we believe that this is a program that can be replicated and expanded. And we hope to see that in the future. And I think it can be adjusted to different geographic settings. Certainly there will be other challenges like driving time between visits that would have to be addressed. But I think with the right funding and visit model, you certainly can do that. Yes.
Perfect.
Yes, certainly. I think that I was just going to say, if you know any physicians that are willing to open up their practice to doing house calls, that is key. And actually, when we accept referrals, we always will go first to their family physician to say, hey, have you ever considered maybe at the end of the day going out and seeing this patient? We're really trying to encourage, because I think that's the key. I mean, yes, funding is a huge piece, but it's also finding the physicians that are willing to do this type of care.
Agreed.
So we also had a question about other team roles, for example, such as, I'll batch a few together. One was asking about, like, do you have, how do you work with pharmacists, or do you have a pharmacist who can work with you on the house calls team? And another aspect was, how do PSWs and home care kind of fit within your model as well?
Mm-hmm. I'll speak to the PSW piece, and if you want to speak to the pharmacy piece. So our PSWs are our allies, and when we're out there, certainly they're usually our first point of contact, as long as we have consent from our patients to speak with them, because they really are the eyes and the ears, and they're there every day. We do work with, as I mentioned, we have our LIN case coordinators who attend our rounds, and that's usually when we're bombarding them with questions saying, how many hours of PSW is this person getting? Can we advocate for an increase? Can we, get the contact of the care coordinator and try to coordinate our services? So yes, PSW is a huge piece. Because we're from VHA and Sprint Senior Care, we have good lines of communication with some of those supervisors, but we definitely try to work with some of the other agencies that are working with our patients. And Christa, if you want to speak to pharmacy.
Yeah, in terms of pharmacy, we have in the past had consultant pharmacists work with our team. One of the challenges is that our patients are so geographically spread around the city that they use multiple pharmacies. I'm not sure. I think we have more than 100 to 200 pharmacies in our EMR that we send faxes to. So yeah, we certainly, with their individual pharmacists, I have many conversations with them around medications and the best means of delivery. And so yeah.
Perfect. Yeah, and I think that's the opportunity that if you were to receive funding to have a home visiting pharmacist as a member of your team, you probably welcome that too. Yeah.
We love everybody.
We do. And we never turn away funding, Samir. You know us.
I know that, exactly. I can answer this one question was, folks were asking about, is there a certain age, and then understanding about how do you identify your most vulnerable home care clients, and what are the eligibility. But I can start with the fact that, yes, house call serves clients over 65, but perhaps you can talk a little bit about, the clients that you are obviously choosing to serve.
So all of our eligibility is listed on our website at seniorshousecalls.ca. And ultimately, they have to live within our postal code. That's sort of one of the key. They have to be over 65. And then if you, just when you're thinking of your caseload, if you go back to that Venn diagram and you think, do my clients fall into at least two of these categories? Then yes, certainly we would look at them. Currently, again, it's a little bit different because we're only trying to care for those that are very medically complex and prevent hospitalization. But pre-COVID, that was a very easy guideline to follow.
I think that the sort of
now, and we do have we go through a preliminary assessment and screening once we get referrals. So that is just a reminder that not all referrals made to our team are guaranteed, and you can just explain that to the families.
Yeah. The line that we like to use is, does this person have difficulty accessing primary care when they need it? That's sort of the question that we ask ourselves continuously when we think about a patient and whether they'd be eligible.
Perfect. Okay. So again, there's some great questions as well. And so hopefully, Christa and Leslie, we can get you into the Q&A just to answer some of the ones related to your program and that. So terrific response just from the chat room and the Q&A. So thank you very much. And ladies and gentlemen, we'll now move towards a 10-minute break so people can stretch and take a little break, and then we will be starting back promptly at 10:40, hearing about mental health needs and for both caregivers and care providers as well.